Presenting a case of IPCL. This female is a 25-year-old with a spherical of minus 10.5 with a minus 2 cylinder. We are going to implant IPCL, which is customized and to be placed at 180 degree. Starting with two side ports, injecting lignocaine with a mydriatic, and then injecting viscoelastic. These are just a little viscoelastic to form the anterior chamber for the main incision. Once the main incision is made at 180 degrees, then we go and fill up the AC, but never too much so that there is no bowing of the iris posteriorly. Following this, we start injection of the IOL. The bubbles that you see here shouldn't have been there, and the visco should have been injected a little more from the top of the cartridge. So slowly injecting the IOL very gently in a very controlled fashion to see that both the holes are facing the upper eyelid. Once the IOL is injected, injecting some viscoelastic on top of the IOL so that we can enclave the haptics. Now going with the enclavator, pushing the IOL towards the opposite side with the enclavator and then gently pressing the haptic down on the iris and with a slight rotational movement. As you see here, the two haptics have been enclaved. Going with the other hand, first the central small nudge and then enclaving the two haptics one by one, pushing the IOL in the opposite direction, and a slight rotational movement helps in a easier enclavation of the haptics. So the last haptic is rotating the IOL and making sure it is matching the 0-180 marked on the limbus. So this is the final position. After this, the visco wash is very important. In this, I use water jetting initially to remove all the visco from the corneal endothelium and dislodge the visco from the angles. Some people do hydroimplantation or also use a cohesive viscoelastic so that it comes out as a bullous. However, I prefer to use HPMC, which gives a very controlled implantation of the IOL. So once I've cleared up the viscoelastic, I seal the main wound and then I go in with a bimanual irrigation aspiration. With this, the aspiration is perpendicular to the central or the other holes that are there on the IPCL to remove all the viscoelastic from under the IPCL. The irrigation is kept there. The irrigation aspiration ensures that we have a complete removal of the viscoelastic. A thorough visco wash is required, otherwise we see patients having a mild IOP spike post the IPCL implantation. So once this is done, we do the hydration of the ports, the side ports, and I prefer to keep a very soft tie so that even with mild spike the patient does not get uncomfortable. So this is the hydration of the ports. Once we ensure that the ports are watertight, after that we seal up all the incisions and do some paracentesis to have a slightly softer eye. Here you can see I'm doing the paracentesis and checking the pressure, and once it is soft enough, that marks the end. As you can see, a well aligned IPCL